Okay.
Mm.
And Andy, you're up first.
All right. Well, when we think about attachment and personality, we don't necessarily think of genetics, and that would be a mistake. Studies have shown that personality, predisposition to anxiety, and relationships actually have a genetic underlying component. And I love to use a particular study to sort of give an example of that. It's one by a woman named Stella Chess from many years ago, where she took hundreds of children and assessed them for anxiety at birth. So the obvious question is, how do you know if you have an anxious newborn, right? They're not going to tell you. They're not going to share much. Well, what they do is they look at response to change. Change could be a new nurse, turning the radio up in the unit, a new smell, all different new sounds. Those are all examples that may challenge an infant to see how it responds to change. And then the question is, okay, fine, you've made these changes. What are we measuring? What they would measure would be heart rate, blood pressure, respiratory rate, skin temperature. These are signs of an enhanced anxiety state. She categorized these children into the non responders, the moderate responders, and the heavy duty responders. And then 7 years later, tracked down these children and looked at them. And lo and behold, the ones that showed the early signs of anxiety were now the ones with separation fear, attachment problems, and things you would expect with someone from anxiety. They also documented that there was a higher rate in family members. So this is fascinating to me because it's a clear manifestation of genetics. Because it's really hard to be a bad parent the first hour of life, I guess, unless you drop the kid on its head when they hand it to you. So this just shows that, yeah, it's multivariable. Parenting is incredibly important. That's not what this is saying, but it does show that there's that innate substrate that we have to work with. Um, and other follow-up studies showed that people with anxiety and relationship issues that they were prone to genetically had higher levels of separation and divorce. And they saw that in twin studies. Now, I want to bring up a term called the resilient adolescent. That's a term used to describe a teenager that tends to have for some reason, a built-in protective factor to trauma and environmental stress. When they looked at children in the same family, they did not all respond the same. And there may be one, for some unknown reason, handles things better and seeks out and finds healthier relationships without attachment dysfunction. I threw that out there because I think it's important to know that if an individual grows up in trauma, the environment is very stressful, not to throw in the towel and not say, look at the trauma, look at the genetics, because there are some individuals that just have this innate survival. Not sure what causes it, but it's there, and we want to tap into that and know that they have even a better opportunity for a healthier future than they might look. Now, trauma itself actually molds genetics, and that sounds like, how does that make sense? You're born with it. That's your genetics. But think about it. We work with infants, children, and teenagers, and they have an evolving brain. So the book's not finished on them. Trauma has an actual impact on the structural growth of that brain. That person may not have the same outcome in terms of developing healthy relationships, not only because they visualized all the dysfunction, but there is now actual structural and chemical changes in their brain because that trauma occurred at that developmental phase. In other CETs, I've put forth some PET scans that actually demonstrated the metabolic and structural changes in an individual who survives trauma versus a scan of somebody that had a brain who did not go through that. Lastly, on the slide, I just want to mention the trauma impact on sensory input. The way an individual perceives, categorizes, and approaches sensory input is different. In cases of significant trauma that result in PTSD, the brain may re-experience the stimuli when it's not there, or may misinterpret real stimuli as greater, and may actually misinterpret the time frame of when that stimuli is coming in. And instead of seeing it at that moment, may go back to the past. So the accuracy is off, and that's very, very important in terms of somebody trying to feel safe amongst new people and have proper relationships and attachments with them. Okay, chemistry of attachment. Oxytocin is a very interesting hormone. It's produced in the hypothalamus and it's stored and released in the posterior pituitary gland. It's been known for a very long time that this hormone is necessary for uterine contraction and to initiate lactation. However, studies have shown through the years it's also associated with human behaviors, particularly attachment. So it's called, I love this name, it's called the cuddling and love hormone, which is such a cute name for it. And there are actually natural ways that have been shown to increase the oxytocin. Things such as massage, yoga, music, hugging someone, petting a dog, exercise, and of course, sexual relations. So now a disgruntled husband can say, well, we need to have sex so I can help up your oxytocin level. We'll see how that one goes over. But it also plays a role in men, which is funny. It's not been measured in men. There's not been a lot of studies, but it shows that it is associated with their ability to bond to the child. It's also associated with sperm production and testosterone, which has obviously a lot of other factors in terms of being fertile and being able to have a child in the first place. Now, here's an interesting thing for our guys. There's some research that shows oxytocin levels are reduced in the autistic population. So now you have to wonder how that plays into the impairment in social skills and relationship. Is it causation or correlation? We don't really know yet, but we know that it tends to be there. And I think it's something that has to be studied further and see if that's an area of that could be addressed early on, perhaps in a treatment way. Now, in infants, the oxytocin level goes up when they're placed upon their mom after birth. The warmth, the smell, the breastfeeding, all that leads to an increase. If neglected, and it's certainly possible in this case with this individual, Jesse, maybe not getting the intimacy and the care that he required, does this now have a long-term effect on the oxytocin production later on? And does it then have an effect on their attachment into relationships later on? So this is all research that's going to need to be further done. Lastly, on this slide, I want to bring up cortisol. That's the stress hormone. I think most people are familiar with it. Now, the stress hormone leads to an increase of the same in infants. If it's up in their mom, it's going to be up in them. So what happens if you have an infant with a higher cortisol level? They're more prone to anxiety, to panic, lack of trust, and therefore probably an impairment in their attachment behaviors as well.
Great. Before we move on a little bit, I know that the chemistry of attachment and genetics is a complicated arena, and like Dr. Kent said, is often overlooked. So are there any questions on these topics before we move forward?
Yeah, I actually have a quick question.
Yeah.
So, Dr. Kent, I'm curious. So, if a baby is in utero, mother is repeatedly exposed to stress, she has elevated cortisol levels. Does that in some way, I don't want to say hardwire, but for lack of a better term, hardwire the baby to be more susceptible to stressors?
I think the odds are good because we know it crosses the placental barrier, and we know that there's intrauterine growth retardation in high-level stress moms. So the brain is developing. My guess is again, I don't think there's real hard proof of it, but I think the odds are very good that it will have such an impact.
Thank you.
Great question. Any other, I only can see a few people on my screen, so if there are any other questions, just feel free to unmute and join in the discussion.
I was just gonna say, I think it's interesting being a mom who's been pregnant, they warn you about stress and things like that, but they do it from more of a secondary and a passive, like, oh, if you're stressful, the following implications could happen because of it. You may go into early labor, you can have high blood pressure, et cetera, so forth. But the actual, I guess, active in the moment implication of it, I think is insightful, because I wouldn't have known that. I think they really do focus on the secondary implications, the things that could happen as a result, and saying, oh, no, if you're stressful, that is going to, or could potentially, there's a strong connection directly affect, not just other things could happen. I think that that's something that they really don't share with first-time mothers. At least I didn't get that information. So it's interesting.
Let me just point something out. When I spoke with, there's a guy, Dr. Lee Cohen at Mass General Women's Health. He's one of the national experts on treating pregnant women. And when I asked him about continuing antidepressants and medication during pregnancy, he said, you have to weigh just what you and Bob said. What is the impact of panic, stress, and anxiety on the development of that infant, that fetus? And his opinion was very strongly not to get rid of the medication, precisely for that reason, that we don't know, but the odds are it's really not going to be good for the development of that child to let the woman willy-nilly go through such severe anxiety and not try to treat it and reduce it. So that does get factored in, but you're right. I don't think it gets expressed to the pregnant women as much as it should be.
Absolutely. Okay, so to move forward, attachment styles are categorized by different ways of interacting and behaving in relationships. During early childhood, these attachment styles are centered on how children and their parents interact. In adulthood, attachment styles are used to describe patterns of attachment in relationships with others. The concept of attachment styles grew out of the attachment theory and research that emerged out of the 1960s and 70s. Attachment is a special emotional relationship that involves an exchange of comfort, care, and pleasure. The roots of attachment was first researched by Freud, Freudian slip, on his theories about love, but another researcher is usually credited as a father of attachment theory, which is John Bowlby. He devoted extensive research to the concept of attachment, describing it as a lasting psychological connection between human beings. Our early attachment styles are established in childhood through the infant caregiver relationship, which Dr. Kent talked about within the chemistry slide. In addition to this, he believed that attachment had an evolutionary component. It aids in survival. He believed that there are 4 distinguishing characteristics of attachment. Proximity maintenance is the first, which is the desire to be near the people we are attached to. Safe haven, which is returning to the attachment figure for comfort and safety in the face of fear or threat. A secure base, the attachment figure acts as a base of security from which the child can explore the surrounding environments. And separation distress, anxiety that occurs in the absence of the attachment figure. Today, there are 4 typically recognized attachment theories. Children who are securely attached generally become visibly upset when their caregivers leave and are happy when their parents or caregivers return. When frightened, these children will seek comfort from their parent or caregiver. Studies have shown that securely attached children are more empathetic during later stages in childhood, and these children are also described as less disruptive, less aggressive, more mature than children with ambivalent or avoidant attachment styles. As adults, those who are securely attached tend to have trust in their long-term relationships. Other key characteristics of securely attached individuals include having high self-esteem, enjoying intimate relationships, seeking out social support and connection, and an ability to share feelings with other people. Children with avoidant attachment styles tend to avoid their parents or caregivers. This avoidance often becomes especially pronounced after a period of absence. These children might not reject attention from the parent or caregiver, but neither do they seek it out for comfort or contact. Children with avoidant attachment show no preference between a parent and a complete stranger. As adults, those with avoidant attachment tend to have difficulty with intimacy and close relationships. These individuals do not invest much emotion in relationships and experience little distress when a relationship ends. Children with a disorganized, insecure attachment style show a lack of clear attachment behavior. Their actions and responses to caregivers are often a mix of displaying dazed behavior, sometimes seeming either confused or apprehensive. And lastly, children who are ambivalently attached tend to be extremely suspicious of strangers. These children display considerable distress when separated from a parent or caregiver, but do not seem reassured or comforted by the return. In some cases, the child might passively reject the parent by refusing comfort, or may openly display direct aggression towards the parent. As adults, those with an ambivalent attachment style often feel reluctant about becoming close to others and worry that their partner does not reciprocate their feelings. This leads to frequent breakups, often because the relationship feels cold and distant. These individuals feel especially distraught after the end of a relationship. So trauma impacts 3 areas of well-being overall. In regards to attachment, the area of well-being that is impacted is the social area. Within the social environment, our ability to have healthy attachments are affected by traumatic situations we are placed in. Going back to the case Jesse, as Jessica talked about, he experienced potential traumatic experiences during home visits with the mother's boyfriend. There were seemingly symptoms that were related potentially to neglect or abusive situations when he returned to his residential program. And then he also had potential traumatic experiences in the second children's residential program, with the mother describing rug burns. And we say potential because there was no investigation, unfortunately, but how they were described by the family, they definitely does appear. And I think Jessica had mentioned it, but that program actually did close after he resided there due to abuse and neglect in the residential program. So it is highly likely he did experience some traumatic experiences. And then obviously we are going to talk about this in depth in a future slide, but all of these moves are considered traumatic as well. There are 2 different, though equally devastating ways that a child can become abandoned. So the physically and the emotional abandonment. A physical abandonment will occur when one or more of the child's primary caregivers disappears from the child's life. So this could be through death, this could be through divorce or moves. With Jesse, he was moved and removed from the home, which is a type of abandonment on his part in being removed from that home environment. Emotional abandonment will occur when the caregiver is present, but emotionally unavailable. And abandonment in any form can lead to serious psychological problems. Also, parents placing their children in residential programming, which again, like I said, I will talk about in depth in a future slide, can also lead to the child feeling abandoned, even if the parent is doing what they feel is the best thing at that time in order to support them. This is definitely true in this case, Jesse. It's very possible his placement at a young age, as well as his parents voluntarily giving up their rights to DSS, could lead to feelings of abandonment that he may still struggle with to this day. Especially his mother, while he was in placement, moved out of state, effectively causing that natural support to be even further in distance. And seemingly, we don't know, obviously from Jesse's point of view, but starting a new life without him could be something that he feels. One common effect of childhood abandonment is low self-esteem. The child may believe that they were abandoned because they did something wrong, or they're just simply not good enough to live up to their parents' standards or their expectations. The child with low self-esteem often tries to be extra well-behaved. They may become a perfectionist or seek to validate their self-worth with achievements. If they fail to reach their often unrealistic goals, they may become very depressed or even suicidal. A child in this situation could also become easy prey for abuse or neglect because they will typically do anything in order to please the people that are important to them. Children who are abandoned may also develop the attachment disorders. They may be more likely to develop if the child was abandoned by both parents at an early age because they were prevented from attaching to their primary caregivers. They also may not know how to connect with anyone else. The child is also likely to be withdrawn or isolated. They have trouble trusting others. They may be very hypervigilant, watching what's going on around them. Unlikely to engage or try to join in those activities. When a child with an attachment problem is upset, they will often not seek comfort from others, nor will they accept it when it's offered. They're the perpetual outcast or loner. This child may grow up to be unable to empathize with others as well. A third reaction to an abandonment is anxiety. Like the child with an attachment disorder, the anxious child does not trust. However, the anxious child may cling to others and live in dread of yet another abandonment. Unfortunately, their fear often becomes a self-fulfilling prophecy. Adults and other children may be put off by the anxious child's neediness. Child abandonment can cause serious psychological effects. If it's not treated by a compassionate therapist who has experience in working with neglected or abandoned children, these problems and dysfunctional ways of viewing the world may persist into adulthood and cause problems in jobs, adult relationships, and various other domains of their life. So although adoption was not a factor in Jesse's case, Dr. Kent and I felt that this was a really important sector in regards to attachment that we should still cover. So while adoption is unique, it's an emotional, legal process, it entails several challenges, it does have benefits for the family as well as the adopted child. Even though adopted children typically receive great care and attention equal to their non-adopted siblings, certain factors may still affect the adopted child. Academics is one of these areas that may impact the adopted child. They may not be able to outperform non-adopted siblings or other children in their peer group. Depending on the age of their adoption, this could be due to a lack of attention or support on academics prior. The adopted parents taking in special interests and providing encouragement may assist the child to excel in their areas of reading and math specifically. Feelings of rejection and abandonment are a very real concern for someone who is adopted. This can happen even for children that are adopted since birth. Once they find out that they are adopted, it may cause them to feel abandoned by their birth parents and lead to questions as to why they were put up for adoption, or feelings of being unwanted by their birth parents. For children that were adopted at an older age, they may have experienced multiple moves, foster care placements that did not end in adoption. They may have experienced trauma, including abuse or neglect that led to their adoption status or failure of foster care placements. All of these experiences will possibly lead to feelings of rejection and abandonment. Along with grief, an adopted child may react to the loss of their birth parent with anger, numbness, anxiety, fear, and depression, and mourn to learn their birth culture. Mourning for the birth culture is more prominent in transracial adoptions. The child may make an effort to learn and speak their mother tongue and learn more about their birth culture and linguistic heritage. Adopted kids are eager to learn more about their biological family, their siblings, their relatives. They may have questions such as who they are, do they resemble their mother or father, do their siblings resemble them, who are their family members, their grandparents, aunts, uncles, cousins, etc. They also may question what social, cultural, and educational class they belong to based on their adoption status. Another area that really does affect the children who are adopted is their medical history. So oftentimes the adopted parents may not have full knowledge of the medical history of their adopted child and the biological family. They really can struggle to find out any medical history that led to their adoption. I know oftentimes when Dr. Kent and I are consulting on cases and we have a child that was adopted, that's the first question we ask is, do we know anything about the biological family, psychiatric, medical history, drug, any substance abuse history that may have led to the adoption as well. The lack of medical information can be really challenging as it may fail to reveal whether they are at high risk of suffering any ailments due to the heredity and the line of treatment that might be most effective. This impacts both medical diagnoses as well as psychiatric. Are there any questions thus far? Anything in the chat box, Dawn, before we move on? Nothing in the chat box? Okay.
No.
All right. So residential moves, and we will definitely bring this back to Jesse. And just to note that the picture on the screen is actually a true residential program that I worked in many years ago in upstate New York. And as you can see, it's very large. It had even more, it was like 150 acres of land, which is obviously way more than what's even in the picture, but that is a true residential program in upstate New York. In many systems, residential placement are necessary for both the safety and well-being of the individual or those in the family home. And like Jessica stated, at a very young age, his behavioral health symptoms were really impacting not only this single mother, but also the other children in the home. And she really felt she wasn't able to provide a safe environment. So residential school placement can provide structure, treatment, academic support, behavioral support. Of course, we're focusing on the impact related to trauma today and attachment today, but there are benefits to quickly mention. The most commonly reported area of improvement following residential experiences is the reduction in clinical symptoms. There were also long-term studies that I looked at that discuss the long-term benefits of a lower risk of being involved in the criminal justice system, which was an interesting finding. While they do all of that and they have some positive outcomes as well, the impact of being removed from one's family at a young age and having those disrupted attachments can be great. There's a significant amount of research regarding the impact of separation on child development. There's an indication that separation that occurs earlier in a child's life have greater impacts. This research has influenced a reduction in the use of residential placements under 9 years old. In fact, I have worked in the residential school systems for many years prior to coming to START, and many programs don't even take children now until 9. There's been a change in that. There are a few, but there has been a lot of change in even just the age that will accept. I worked in one that wouldn't take anyone till age 11, and that was based in this research, which is interesting. Although peer relationships and relationships with staff can be a positive aspect of the experience, there are also varied concerns regarding the quality of those relationships. There is a risk factor of bullying while in the residential experience. And of course, Jessica did mention the possibility of Jesse experiencing abuse and potentially even neglect for his needs while at one of his residential school placements. In research in 2003 found that early residential mobility was negatively associated with poorer physical and mental health. Moving between multiple residential placements is very disorienting for a young person. They not only experience the disrupted attachment with their family system at the initial placement, but then they experience continued disrupted attachments with each move. In addition, every program has different expectations, rules, structures, so they're forced to quickly adapt to a new environment each time. These moves might also bring them further from their natural support, which then can change the frequency of any visitation with their family. Research has shown that children who move frequently tend to do poorly in school, and there is report of more behavioral symptomology. Adolescents who move frequently as children are more likely to smoke, consume alcohol, and attempt suicide. The negative association between residential moves and well-being could be driven by social relationships. Friendships in childhood give the individual a sense of social competence and provide a solid foundation for the formation and maintenance of social relationships in adolescence and adulthood. These moves force the individual to completely uproot their social relationships and they're asked to recreate social networks each time. This is definitely an area that has impacted our case, Jesse. So as Jessica outlined, Jesse was hospitalized at an early age at age 6. He was then transferred to a residential school program, removing him at such an early age from his family home, placing him in a different and unknown environment. As I just said, as well, research on residential placements prior to age 9 have been detrimental, and therefore it's currently less common to even do so. During his stay at the residential school, he was again hospitalized, which is unnerving for the child. It can be uncomfortable, disorienting. It can also make them feel that their current placement and staff are abandoning them as well and lead to those fears of rejection. After 12 years at his original placement, he was moved to a new residential school, which I'm sure all of us can imagine how unnerving and troublesome that would be for Jesse. Not only was he once again being moved, but he was leaving connections that he had made over the course of 12 years. That's the majority of his childhood. It was spent in that original residential school, which, according to the reports, there weren't concerns of how he was being treated. Yes, he had the behavioral health concerns and some of the issues following home visits. But 12 years is a really long time, and you build a lot of connections with people, an understanding of the program, the expectations. In addition, once he left that original school, he was moved out of state to a new program further away from his natural supports, again, with the propensity and probability of an abusive situation that he was then moved into. As we also heard from Jessica, his moves did not stop there. He has had several subsequent moves in his young life, all of which have disrupted his social connections, his comfortability, and has likely led to an increased concern and attachment and feelings of abandonment. So again, this is a really big area of this case. So I just want to pause and see if, Jessica, if you had anything to add about Jesse, or if anyone in the training has any questions or comments related to this arena.
Yeah, I think it's really interesting just to look at, like, even like Jesse now, like he has a really hard time like building relationships, and like even throughout all his residential moves, he really didn't have that opportunity to form those attachments with others, staff or housemates. While he was at his first like children's residential placement, he actually had like a one-on-one like outside of his room at all times. So I'm sure that also kind of didn't help building the relationships, but I find it really interesting.
Absolutely. Absolutely. And again, a lot of these decisions, especially for a child at young age, are made because of, their safety, their well-being of others in the home. And we have to obviously take that into consideration, but it is really interesting. When I worked in the residential school domains, oftentimes we were maybe their third stop. I worked in Massachusetts, out of state from New York, obviously, for many years. And we did take New York individuals. And oftentimes we were their fifth or sixth stop until they got to our specialized program and our level of care, which was much higher than some of the other programs. And, I remember one day I had worked at the residential school in the picture for many years. And then I moved to the Massachusetts program. And one day I see a name and I realized I worked with him at the previous program. So I was a part of his transition. And he actually like teared up because he had a familiar face. And to me, that just showed how anxious he was about a new environment, not only a new state, it's further from home. He also had other concerns. He was actually living on the streets for a while, so who knows what happened to him. But that comfort of having someone that he recognized and that had supported him for many years prior was helpful to him. But most of the time that doesn't happen. We actually have an individual in START that I worked with in Massachusetts, which is an interesting experience as well. When they returned to New York and they came to START, I was like, hey, I know him. And it was an interesting experience. So, but that often doesn't happen. So these moves, the inability to make social connections, the inability to build their comfortability and trust others, someone that's gone through as many moves as Jesse, I'm assuming he's always waiting for the next move. He's always anticipating, when are people going to reject me or abandon me? Or if I do something wrong, is something going to happen? Am I going to have to get moved again? We'll talk more about this later in the presentation, but you had mentioned too that he is doing well because of the feelings of safety and trust. And that's huge in this current placement. It's probably one of the most important things that they could do to build with him right now, for him to know that they're not giving up on him. Okay, so we will continue. Okay, so obviously, when you look at the autism and ID population, there are difficulties in diagnosing, and there are difficulties just in working with this population when they have the attachment and the trauma on top of it. So the thread of atypical social responsiveness and atypical positive affect runs through both autism and the attachment disorders. There have been studies comparing children with autism and children with reactive attachment disorder, which found a substantial number of children with RAD scored in the clinical range on the social domain for autism on gold standard studies. This overlap also becomes more acute when the symptoms such as avoiding eye contact are included in conceptualization and assessment for RAD. The most important differential between autism and attachment disorders is a history of insufficient care. Yet, this is not a clear-cut indicator when you think about attachment difficulties more generally, given that neither insecure or disorganized attachment imply neglect or insufficient care. Even thinking about our case, Jesse, yes, he had all of the disruption, he had the moves, he was placed at a young age, he has the trauma, but having that overlapping diagnosis, it does make it complicated for him to get, the right diagnoses and the right treatment. There is research that the severity of the individual's autism was associated with more attachment insecurity, and lower developmental level increased the change for disorganized attachment.
So following up with from Elisa's slide, I figured I would go through the actual psychiatric diagnoses you guys will see when we're working with these individuals. Reactive attachment disorder is a very severe, consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers, manifested by several things. The child rarely seeks out comfort when distressed. They rarely or minimally respond to comfort when distressed, even if it's given to them. There's persistent social and emotional disturbance in relationships and minimal social and emotional responsiveness. There is a limited positive affect. One sees episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with those adult caregivers. In addition to the above, the child has experienced a pattern of extreme and insufficient care as evidenced by at least one of the following: social neglect or deprivation in the form of lack of basic caretaking, such as emotional needs for comfort, stimulation, and affection; repeated changes of the primary caregivers that limit opportunities to form stable attachments. Well, that sounds familiar to what you guys were just talking about with Jesse. Rearing in unusual settings that severely limit opportunities to form selective attachments, such as an institution where there's too many children to available staff. When making the diagnosis of reactive attachment disorder, they have to evidence it before the age of 5, and the criteria is not met for autism. So that's a rule out diagnosis there. Now, another one is disinhibited social engagement disorder. Here, there's a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults and exhibits at least 2 of the following: reduced or absent reticence in approaching and interacting with unfamiliar adults; overly familiar verbal or physical behavior that's not consistent with culturally sanctioned and age-appropriate social boundaries; diminished or absent checking back with the caregiver after venturing away; willingness to go off with an unfamiliar adult with minimal or no hesitation. And these behaviors are not due to the impulsivity of ADHD. The other criteria in this disorder is that the child has experienced a pattern of extremes of insufficient care, as evidenced by either social neglect and deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection, or repeated changes of primary caregivers that limit opportunities to form the relationships due to several or multiple moves. So basically, these diagnoses manifest that the upbringing, whether it's causing chemical changes, physical changes to the brain, like we talked about before, or just from role modeling behavior, there's severe impairment in the ability to form healthy relationships. So again, this was a bit of a dry slide, but it shows you these are the actual diagnoses that you will see when we do the consultations.
For anyone not familiar with the DMID2, Dawn, our team leader, is putting the link to the manual in the chat box for you to look at this later after the training. So pull that out. This is a diagnostic manual for mental disorders in persons with intellectual disabilities. It provides research, thorough discussion of the issues involved in reaching an accurate diagnosis, and provides modifications of the diagnostic criteria based on the individual's level ID. So everything that Dr. Kent just stated from the DSM and how we look at these diagnoses, this manual provides modifications in ways to look specifically based on level of ID, which is really helpful. Very surprising to us here at START, many professionals in the field are unaware that this manual exists. It's extremely supportive in facilitating an accurate diagnosis for individuals with ID. back in last March when, we were all shutting down, and I was told by, our director, take anything that you need. We don't know how long this was going to last. I don't think anyone thought it would be, almost 11, 12 months. But the first thing I put in my car was my DMID2. This is the thing I need. It's always sitting. It's right next to me. It's always next to me for consults. I'm constantly, reading it. It's a really great resource for anyone in the field. In reviewing the diagnostic barriers in the DMID discussions related to the attachment disorders, there were a few main takeaways. So these were the congenital and genetic factors that influence an individual's ability to attach. So looking at the level of ID, looking at their genetic factors in relation to attachment, and making sure that those are brought into the picture. The rates of development, how someone with ID might develop later than an individual that's neurotypical, their communication and cognitive deficits. This is a huge diagnostic barrier, I would say, across the board. I feel like it's mentioned in probably every diagnosis in the DMID. Oftentimes with a lot of the DSM diagnoses, the communication piece of being able to communicate, if you look at OCD, one of the criteria is their ability to communicate their, dislike for their routines. In our population, that's not always possible. They may communicate that dislike in other ways, and we have to take that into consideration, or they may not be able to communicate that at all. And then the sensory deficits and how that impacts, and Dr. Ken had touched upon that in the earlier slides as well. In each diagnosis, they have modifications for the criteria in the DSM-5. Overall, there were some main themes in relation to the modifications in the attachment disorders. The first is ensuring that the evaluator is assessing them from a developmentally appropriate level. So again, that goes back to the fact that our individuals with ID, they may be in their 30s, but they may be at a lower developmental level. So what is appropriate for that developmental level, not necessarily their age. The DMID also includes agitation and aggression as indicators of distress. This relates back to their communication and cognitive deficits. So they may not be able to communicate how they feel or how they, what they're thinking or what they like or dislike. But by including agitation and aggression as a definition of distress, we are seeing these behavioral health symptoms as methods of communication, which I think is really important when we're assessing the diagnoses of our guys. And the last main theme that I noted is it discusses the need to utilize their measured intelligence and their adaptive functioning in order to assess the diagnoses. So this is also really important. It goes back to the first main theme of the developmentally appropriate factors, but looking at their intelligence, their IQs, their adaptive skills, and taking that into consideration. Again, with the DSM-5, these things are not brought into the forefront because it's focused on a neurotypical person. So the DMID2 is a really important tool that, again, a lot of providers in the field are not familiar with to really ensure that our population is diagnosed appropriately. And again, anyone that's interested in learning more about the DMID2 or looking into it, Dawn did put the link in the chat box. Before we move forward into more of the treatment and those factors, I want to just pause again to see if there are any questions, any thoughts, any comments about Jesse. I do know that we have his BIS Lisa with us, so I would love to hear if you have any thoughts or feedbacks that have come up for you during the training so far.
No, I have no comments at this time just yet, but it's been an interesting presentation so far.
Great, thank you, Lisa. Okay, and there's nothing in the chat box, Dawn? Got a head nod? Okay, so we will keep moving forward.
Okay, so you don't have to be Sigmund, as Elise would say, Sigmund Freud, to know that socialization is a normal part of the human condition, right? So it only makes sense that if someone doesn't have that in their life, you're going to have mental health problems because it's so important. Without the attachments to friends and family that one can trust, there's a sense to turn inward and dwell on negative thoughts and ruminations. So it's common to see a depressive diagnosis in this population where there's poor satisfaction with their lives. They may have vegetative symptoms such as sleep disturbance, appetite disturbance, and you might even see it progress to anhedonia, which is the inability to find enjoyment in things. Without the sense of connection, there may also be an increased likelihood at self-injury attempts. Now, anxiety is a bit of a no-brainer. The world's a much harder place to navigate without a good support system in place. It's much more intimidating, and a heightened startle response is much more likely. That's why we see separation anxiety, social anxiety, and panic disorder often accompany attachment disorders. Now, in the consultations I've done with New York Start and Free, I've seen quite a few individuals struggle with factitious disorders. To people not familiar with what we all do for a living, they may wonder why anybody would want to call the police on themselves, go to the emergency room, or be admitted to the hospital. And then I'll get asked, why would anybody ever want to be probed and prodded until they could find a medical diagnosis? Well, the unfortunate truth is this may be the person's only ability to find nurturing in their mind. This can become their identity. They're not happy with their role as perhaps a father, mother, sister, brother, whatever, and they need to be patient, not patient in that way, but a patient to feel cared about. So that could turn towards the factitious disorders. Lastly, personality disorders such as borderline and narcissistic are often comorbid. Let's think about that one for a second too, because it actually makes sense. Individuals with these personality disorders have a very poor sense of self. Who are they? What makes them happy? Who do they enjoy spending their time with? Are all very, very fluid and uncertain. And typically these people have a very poor ability to self-soothe. So the answer to the question is that they struggle to exist as an entity that feels confident and the ability to survive on their own, and they don't have a great support system. I have a young woman I want to use an example I work with. She had a devastating upbringing of trauma and multiple moves. And when we worked together through the years, she described herself, and I'll never forget it, as a leaf coming off of a tree in the fall. And I asked her to explain what that meant. And she said she kind of just existed, that wherever she landed, that's where she was. She was no more a New Yorker, a Californian, a city dweller, or living on a farm. It just basically wherever the world took her. And her relationships even didn't feel real. She would tell me if she met people and dated a guy or had a friend, that it was more accidental than it was intentional, because there was not sense of how do you really form a relationship and go forward. So I bring that up because I just think we work with these people, and I personally have done it for years, can't really imagine what it's like to live that way. So it's just so critical when the attachments are off and the psychiatric comorbidities that come along with it. Okay, so is there a role for medicine? Well, quick answer, of course, is yes, but that's not the end of the slide. Clearly, there's no attachment disorder medication that's going to fix that. But think about one of the previous slides regarding the comorbidities. Think about all the suffering and symptoms that people are forced to endure. This must be explained to the individual, their caretakers, and their systems that although this situation is based on trauma and attachment disorders, that if we make them feel more comfortable, that might still be helpful. Other type of therapies will be discussed later, but they won't work if the person's in crisis. Sometimes we have to medicate to get him out of the crisis. Always love the example one of my mentors gave me is, if you're drowning, do you really think a swim coach is going to work well on the finer points of a breaststroke? No, they're not. You just have to survive first. And that's often what medicine is about. So I'm not turning this into a pharmacology lecture, but I want to go over a couple basics. If the person presents with depression, obviously we'll look at antidepressants. If there's mood swings and they're severe, we look at all the other medications that help with that. The one pharmacology point I want to bring up is that in our population, we tend to see, I think, a little bit of an excessive amount of atypical antipsychotics to treat mood swings in the developmentally disabled person with an attachment disorder. If there's physical aggression and it's dangerous, then so be it. My only point that I want you to take from this lecture is there are other mood stabilizers that might be considered that may have friendlier side effect profiles than jumping right to the antipsychotics. So that's something we try to point out in our consultations. Now, this may or may not apply to Jesse. I'll let everybody let me know. But if there's a hyperarousal that causes the agitation, an overreaction to the world around them, that is very associated with structural changes in the brain and how I spoke before about misinterpreting sensory input. So that's actually a very practical pharmacologic point, because in those situations, we may look at things like clonidine, guanfacine, and propranolol that specifically address autonomic arousal, which means, again, the nervous system overreacting. And they're also particularly good in self-injury, which I know is an issue with Jesse. Insomnia also, of course, needs to be addressed, because regardless of the disorder, insomnia tends to worsen everything. So we may need to use something for that. And OCD, which I think I neglected to mention as another comorbidity, is a commonplace phenomena as people need to structure routine and predictability when their life is so precarious. Then we need to look at medications such as serotonin reuptake inhibitors if they're having severe OCD symptoms.
So I just, I had a direct message from Eileen asking if any over-the-counter medications could be helpful.
Well,
I'm thinking supplements, I'm thinking that's what she's asking.
for which aspect of the comorbidity, for which aspect of symptoms are we talking about?
Eileen, can you clarify? Yeah.
Yeah, anxiety.
Okay. Well, there are plenty that are reported to be helpful. And in my particular practice, I'm using a little more of CBD for anxiety, for sleep. Got to be careful. They're not FDA approved. They're a little bit more anecdotal. But I am absolutely open to that. Other things I've seen people use are theanine, valerian root, kava. It's always important to have that compiled into a list, because people think, oh, if it's over the counter, it's natural, it's safe. But some of those can interfere with the medications from the provider as well. So the answer is a resounding yes. There are things we could look at. We just want to check out the safety and the interaction possibilities.
Okay.
Dr. Kent, I have a quick question. Just sort of, given what we know about Jesse, and I was taking a look at his medication list. What are some of your thoughts when you take a look at that medication list? And are there areas that, as a start team, we should be sort of looking at and having conversations with the prescriber?
I don't have it up in my head right this second, but clearly I'm a big fan. If we're seeing a lot of anxiety and self-injury and impulsivity, to trying to, instead of using atypicals, to maybe look at the hyperarousal meds like I mentioned. I'm also a fan of using low-dose benzodiazepines when there's a lot of agitation, because I think the person just feels more comfortable in their own skin. And the issues that tend to make people fearful of using those, such as misuse, addiction, diversion, is going to be less common in this population. So that would be sort of a generalized view of with Jesse, where I may want to see if those are more possibilities.
Yeah, I mean, I think looking at his meds, I was able to pull it up while you were speaking. He's on Depakote, he's on lithium, he's on Clozaril, he's on fluoxamine. Those are his psychiatric meds. And when you were talking about kind of jumping right to an antipsychotic, and I see Bob shaking his head, of going to Clozaril, it doesn't seem as though they've maybe tried. And again, this is just the current meds. I'm sure there's been years of trials that we would need to look into. But and when you talked about hyperarousal, I have very few people on my screen, but Jessica is one of them. And I saw like a big, big head nod. So again, I think that there are definitely things that can be done. And, yes, he's doing well right now on this regime, which people may be, a little bit more hesitant to mess with it. But there seems to be some things that we could be recommending, especially in regards to the hyperarousal and the anxiety, that are maybe they're looking at antipsychotics instead of utilizing as treatment modalities. So
yeah, it's just interesting because one of the classes of medications that Dr. Kent talked about was the sort of the beta blocker, which is on board for hyperlipidemia.
Mm-hmm.
And I wonder there might be some sort of secondary benefits. I
didn't even notice that he's on Inderal for his hyperlipidemia. So definitely.
right? It might need a different dosing. I had some person in my practice last week who I needed to switch to the long acting to make it more beneficial for behavioral health symptoms. So if they're on that, and again, I apologize for not having that right up in front of me, that could be dosage adjusted and release mechanism adjusted and perhaps be more effective and kill two birds with one stone.
Yeah. The Inderal is 20 milligrams a day right now.
Yeah, and that's probably not going to cut it for the behavioral health symptoms we wanted to address.
Yeah, so I think there's definitely a lot that can be looked into to provide Jesse with some more comfort from this perspective, for sure. Okay. Any other comments or questions before we keep moving forward?
Okay, on the slide, it looks rather simplistic to say start low and go slow, but nothing could be further from the truth. To all the coordinators, think how many times you've brought cases to me where the meds are ramped up too quickly, started too high, and the dose is inappropriate. Conversely, how often have we seen when they're tapered too fast or discontinued abruptly in this population? And it's a problem because in ID and ASD, they tend to be very sensitive to medication. And you know what? Even if they're not, let's not take the chance and lose them or the system by causing side effects where they don't have confidence in the provider anymore. So it's really fairly easily avoided if we don't go quickly. So the controversial question I've often get is, why does the provider go so quickly? Well, I'd like to give the benefit of the doubt to some and say they're aggressive with the medicine because they want the person to feel better as quickly as possible. But unfortunately, there are some that do this because they don't want to take the time to titrate and discuss with the individual and the system how they do each step of the way, which is unfortunate because that's very helpful. That's beneficial because you find the right dosage without the overshooting. The downside is it can take a little longer and you need to have patience, but I feel that's a better way to go. The other thing I put in here is to watch out for piling on. What I mean here is individuals change providers often. Doctors add medicines trying to help. Problem is if you don't review records, you may add something and forget just what that person is still actually taking. Before any medication is added, any provider needs to know exactly what medicines they're prescribing and what the doses are. If not, it could get dangerous and out of control. And even if it's not dangerous, you'll be getting inaccurate feedback because if the person's not doing well, is it because the new medicine's not working, or is it because it's interacting with the old medications you didn't realize the person was actually taking? So there's a lot of issues there.
I think we see that too, Dr. Kent, when, an individual might be seeing both a psychiatrist and a neurologist, and maybe the point of it's like the Seroquel, the Depakote is for seizures, but obviously, as we all know, there's a mood stabilizing factor there, but they're not either in collaboration, they're working in silos, or they're not even reviewing what the other person is doing. So even if it's not just them not looking at their own psychiatric records to see what the other psych provider has prescribed, I think also we see it when we're reviewing cases within START of other providers kind of also prescribing medication within the realm, and even primary cares or developmental pediatricians, we kind of see it from the gamut, and then they're all not working together, and then it has that piling on effect as well.
Yeah. And one other last point on the piling on part is that it rules out another option you can do, which is addition by subtraction. If I get a case and the person is doing poorly and they're on this big cocktail of medication, I may actually want to lower or remove something and see if there's a benefit there before I even start thinking of what I'm going to add. So that you don't get to do that if you're not aware of everything that's going on. Other point to bring up: watch out for unreported side effects the individual may not bring up. Dry mouth is extremely common on a lot of the meds we use. We have to look out and see if our individuals are drinking more or appearing more irritable, because that could be a sign. Dental problems such as cavities could result because of that, and that's certainly not minor. Constipation is a very common side effect, and I believe that was something Jesse had. Lastly, sexual side effects are often not reported due to embarrassment or even lack of communication. We need to try to seek out this information and just not assume it doesn't exist because you don't hear about it. Informed consent is tricky in individuals with ASD and ID. And with or without attachment disorders, it's more tricky. I mean, if they have attachment disorders, it's more tricky because they may not connect with you and they may not trust you to even have a good conversation about it. So you have to assess that as well as their cognitive ability, and you need to tailor it to their level. And if it's not a sufficient consent, then you then go further to their support system to get a greater degree of consent. Lastly, I want individuals in the systems to know that if I use something off label, we've gone over this in many, many other CETs, but if it's not FDA approved, it does not mean you can't use it. It does not mean it's illegal. It does not mean the doctor screwed up. It just means that it's something that we know anecdotally could help. There may be some incomplete research on it, but we have to just explain that to the people on it or the support system. This is the pros, this is the cons, and this is why we were picking something. And what Bob and Elise brought up about propranolol, I use a ton of that for anxiety. It is not FDA approved. So they have to be aware of that it can be beneficial, even though it doesn't have the formal blessing.
Are there any additional questions on medications or the side effects within this population?
Hi, it's Mona. Not a question, but as far as coaches, because we see individuals on a very regular basis, yes, we have at times, numerous times, have been in sessions, I know I have, where either I notice a client either starting to doze or their anxiety is really ramped up where the week before it wasn't. And I'm a poker, so I will eventually find out that, oh yeah, their dosage has changed. Oh yeah, their medication was changed a few days ago. And then of course I have to report my findings back to my team.
Absolutely. And I think coaching does give us and the START team a really great opportunity for, like you said, that consistent, contact directly with the individual and the system, that sometimes when the individuals are having some of these difficulties, the family doesn't relate it back to the medications or changes. The other time we can really assess for this is using the RSQ, the recent stressor questionnaire that we use at intake, but we also use it anytime a call comes in for the crisis line with START. And it really, we check in what's changed, since the last time we've had contact the next couple of months, what has changed? Has any medications changed? Are there any new medical concerns? But also, has there been disrupted attachments? Has contact with, significant people in their life, has that changed? So I think that, the point you're making, Mona, is really, really big, and you're able to directly assess that. And then we have these other ways to ask the right questions. And sometimes we get that answer of, that did change, but I didn't think about that. I didn't realize that happened. They're often, the caregivers are overwhelmed. They can be just tired themselves from having to manage the behavioral health symptoms, that they're not realizing that correlation until they're asked directly, which is why that RSQ assessment is definitely, I know when you ask Bob what his favorite assessment is, he always says the RSQ, and it's definitely one of mine as well. And also, with our new Region 5 Resource Center, we've been able to use the MEDS assessment a couple of times now. And in really looking at, they seem really tired midday. Is this a side effect? One of the individuals, they were taking Benadryl as a prescribed med at noon. So when they were really tired around 1 or 2, it was yes, there's a side effect, but that's, we know that's a side effect of Benadryl. So we need to look at, is that the right medication midday for this person to be able to flourish in their life and find their flow. So I think that there's a lot of ways that that START can look at these side effects and really educate people about the medications in those moments of coaching or the resource center or using the RSQ. So I think that's a great point, Mona. Thank you.
And I know with Jesse too, it was interesting because with completing like the ABC every 6 months, we noticed like back in April, that his lethargy or like his social withdrawal like increased like dramatically. So just kind of like bringing that to the psychiatric prescriber and being like, hey, like, he had this increase and now we're seeing like he's really lethargic, and she was able to, make the adjustments, to further assist him and kind of help out with that side effect he had.
Yeah, I think that's great. And that's great that you were able to utilize that standard assessment and then bring that to the provider and say, it does correlate with this increase, can we look at that and make some adjustments to support him living, his best life. So I think that's great. Great use of the assessment tools that we have. Okay.
Okay, so this is my last slide, and it's about non-medical therapy, which of course is also indicated in individuals with attachment issues. Individual therapy, of course, is a mainstay, serving multiple purposes that, by the way, not always clear to somebody not in the mental health field. We may take it for granted. Of course, a place to vent and problem solve, but the relationship itself can serve as a role model. Think about any relationship we have. There'll be disappointment, there could be some jealousy, some anger, all kinds of feelings. This can occur with the therapist as well. Being able to work through this and communicate these emotions serves as a blueprint and a place to practice for future relationships. So where is it all, all the more important, but in somebody with attachment issues. Now, DBT, or dialectical behavioral therapy, that came to prominence in the early 80s, and it was a branch off of CBT that keyed in on emotional regulation, in particular in the borderline population. Its goal was to decrease maladaptive behaviors and focus on mindfulness. In other words, staying in the moment and trying to get rid of catastrophic thinking that is not realistic. Patients seek to learn how to tolerate distress, and they do this by going through various modules in group training sessions. They're given homework, they report back to the therapist, and I've had some really good results when some of my patients have gone for DBT. Now, cognitive behavioral therapy comes from a psychosocial background. The challenge is cognitive distortion and behavior. It works with thought challenges and replacement to improve the person's coping strategy. The key in CBT is to identify troubling situations like grief and anger and become aware of the thoughts and emotions that are related to it. The goal is to identify the negative and inaccurate thinking and restore it to more appropriate, realistic thought processes. So you can see they're similar, but DBT tends to work a little bit more on the highly dysregulated emotional component and to try to eliminate maladaptive behavior such as self-harm. Now, EMDR, which I'll probably let someone else say more after because it's certainly not my area of expertise, but it does stand for eye movement desensitization reprocessing. What's going on here is the person attends to disturbing trauma material in brief sequential doses while simultaneously focusing on external stimuli. I've had patients who do it through eye movements, with finger tapping. There's various ways you could do it. The game plan in EMDR is that past traumatic events are processed, forging new associative links with more adaptive information. Current circumstances that elicit distress are also targeted, and internal and external triggers are desensitized, which is a mouthful. So I'll dump this on Elise when we're done with this slide. Lastly, imaginal templates for future events are incorporated to assist the patients in acquiring skills for future adaptive functioning. So the last three therapy noted on here, I'll go through very quick because they're fairly self-explanatory. It's important to work with family members to help them communicate and better understand the individual going through the symptoms. The group is a place where the individual can practice social skills and process feelings and learn how to be more accurate in how their interactions are perceived, because the inaccurate perception is brutally important in somebody trying to fix up their social skills. By being able to bring observations and feelings up in a safe environment can be helpful. It's another example of being able to practice social relationships. Like I said, you can do on the one-to-one. And lastly, milieu therapy. If somebody needs an environmental change, that's what refers to. And I think our resource center is an example of a milieu therapeutic interaction. All right, so Elise, I'll let you fix what I said because I don't know about that.
There's no fixing needed. Just to go back to EMDR, there's a lot of research with utilizing this modality in the IDD population. Although there is some, talk component, it does more focus, as Dr. Kent said, on the tapping or the eye movement. So it's been in research really successful in this population because their communication deficits would not be a factor that would necessarily get in the way. We have actually recommended this to a lot of people within START that have significant trauma histories and attachment difficulties. So it's definitely a I think, lesser known modality and lesser utilized modality. But again, like I said, research wise, with this population, it's really successful because of the lesser demand on communication. And the only other thing I really want to mention with individual therapy and DBT and CBT is that a lot of times we hear that, oh, the person's too low functioning, they can't do therapy. And I think we say this in every CET. So hopefully the more we keep saying it, the more people will understand it, is that that's not true. There are modifications for every modality, DBT, CBT, all the other modalities. There's so many of them. Individual therapy is very successful for our population, even with their communication deficits. I know Jesse is in individual therapy, and that's a consistent for him on a weekly basis, which, like Dr. Kent said, that relationship with their therapist is a really important factor for someone that has attachment difficulties. If they're able to model a positive and protective relationship that they may have missed out on, and support them in utilizing those thoughts and practices with other people in their life, it's a really powerful experience. I think that oftentimes when it's not utilized in our population, it's really a disservice. So again, you want someone that is trained and able to work with our population and make modifications, but there are a lot of documented modifications for DBT and CBT specifically. Okay, so I just want to take a little bit of a focus on PERMA. PERMA is under the positive psychology umbrella, so to speak. And positive psychology is a scientific study of strengths that enables individuals and communities to thrive. It's founded on the belief that people want to lead meaningful and fulfilling lives that enhance their life experiences. So this focus on PERMA within START is really important. Oftentimes when we get referrals or we talk to cases and systems, they talk about just wanting to stabilize the individual. But we want to take it a big step forward and really focus on their wellness, their happiness, and that really comes into play with PERMA. There's 3 pillars of positive psychology. The first is positive experiences, the second is positive individual traits, and the third is positive institutions. A core concept of positive psychology is this PERMA, which is the theory of well-being that attempts to answer what enables human flourishing and what puts a person in flow. The 5 building blocks of PERMA are positive emotions, engagement, relationships, meaning, and accomplishment. PERMA Plus was developed in the last few years, I want to say, and this adds the core elements of health, sleep, physical activity, and adds that into this core being of wellness and happiness that PERMA has always focused on. All of these things is what leads to a person to personal fulfillment, meaning, and well-being in their life. By focusing on the strengths, the START team creates a shift in attention. So we take the typical what is wrong approach and try to reframe it to a what is strong approach. We talk about how to draw on inherent strengths and resources when experiencing adversity. These strength-based interventions can include empowering respectful and reciprocal collaborations between individuals, families, and providers, and drawing upon already existing personal resources to solve problems. These interventions create sustainable positive change through the process of capacity building. So how can a focus on PERMA support someone that has disrupted attachments? In a lot of ways is the answer. So assisting an individual in building what's strong about them while focusing on what puts them in flow will impact their overall attitudes and experiences in the world. This will give them a much better experience of positive emotions. They'll be more engaged into things that matter to them. And in turn, they'll be able to build natural supports and positive relationships with people underneath those strengths that they may share. The more we put on what they do well, their positive emotions, their experiences, their relationships, their nutritional health, the stronger they are in facing adversity. If they have good emotions and good positive experiences to relate to when they're having difficulty, they're more able to work through those adverse moments. Instead of only having contact or discussions when things are going wrong, they won't have those positive experiences to relate to when they need it. The focus on PERMA will also assist an individual in building meaningful and caring relationships in their life, having relationships that are based on the premise of their strengths, their skills, their interests, that they meet their needs, will assist someone that has had previous disruptive attachments flourish. This is really important for Jesse. He needs to flourish. He needs to have these consistent, positive relationships in his life to not feel as though they're always going to end. If they're based on his strengths and his positive experiences, he's going to be able to hopefully open up and really experience that social connection. I also want to point out that it's really important to see the overlap of PERMA with trauma-informed care. A trauma-informed care approach is important in ensuring the person feels safe, trusts those around them, has the ability to choose and have choice in their life. And these facets of trauma-informed care overlap with PERMA, and collectively, it can support not just stability, but wellness and happiness in the individual's life. And just to bring it back to something that Jess had said earlier in her overview, you mentioned, Jessica, that right now Jesse is doing really well in his current placement, and you personally in your overview stated that you feel that it's related to him feeling safe and trust with those providers, which is such an important factor. And when you said that, it brought me to this slide and knowing that we were going to talk about this, because him being able to develop positive relationships with caregivers, especially after everything this young man has been through with abusive situations in caregiver environments, him being taken out of the home at such a young age, having those disrupted attachments throughout the course of his life, especially after being in one residential program for 12 years and then that being disrupted, his parents giving up, his mother giving up his custody to DSS. I mean, there was a lot that happened to him at such a young age that we would all understand why he couldn't necessarily connect with people. And the fact that the current group home is able to build that trust and safety for him is amazing, because they're really kind of coming from a position where it was probably really hard to do. And he's been there for about a year, just over a year. So those relationships are a huge component in building his PERMA, helping him find his meaning in his life, his flow, and helping him have positive emotions and experiences within his current life situation. And I know that right now he is focused, and his mom is focused on moving him to California. I don't remember what part of California, so Noemi, we might be in touch. And I know that the pandemic has put that on hold. And I remember you just talking to me about the mom was upset, thinking people weren't doing enough for him. And you came together with a systems meeting and really explained that we're working on it. There's a lot that goes into it. The pandemic is impacting that, but we're all on the same page. And that collaboration of relationships is also really important for Jesse to see. So again, I just felt that kind of wrapping this up with a focus on PERMA, especially after talking about all of the different therapy modalities. Of course, PERMA is not a therapy modality, but like trauma-informed care, it's a modality to kind of base his treatment on. And for someone with such disrupted attachments, it's, I would say, one of the more important basis of his treatment and of his care that we all are focusing on, even if it's indirectly, making sure that he's having nutritional follow-up, and he does have a bunch of medical conditions that have impacted his cognitive ability, his hypoxia at birth, but making sure that all of those things, his hypolipidemia, everything is being taken care of so he can live his best life. It goes in line with the rest of PERMA. So again, I just wanted to kind of end on that focus of PERMA and how important it is for us to be all working to support Jesse and all of our individuals from that focus. So with that, I want to open it up to the